Hi guys, let's discuss about acute lymphoblastic leukemia today. Acute lymphoblastic leukemia is one of the most important and common malignancy in children, and as the name suggests, it's a proliferation of the lymphoid cells, but it is the proliferation of precursor lymphoid cells, either a B cell or a T cell ALL. Usually it occurs in the children in the age group of 2 to 5 years, and the incidence is more common in male. Actually, the exact etiology is unknown, but some of the risk factors that are associated are exposure to ionizing radiation, chemicals like benzene, and drugs like alkylating agents and radiation therapy. And some have genetic predisposition because it is more common in identical twins, and also if sibling is having, then there is a fourfold increased risk of developing ALL. And some of the chromosomal abnormalities like trisomy 21 Down syndrome, Bloom syndrome, and Fanconi's anemia. This is the clinical features. So we'll have a hematological manifestations since there is more proliferation of the hematopoietic precursor cells. So in the bone marrow, so it will inhibit the synthesis of the red cells as well as the platelets, and mature forms of WBCs will be absent. As a result, in hematological manifestation, we will have all three cell count will be decreased in the form of anemia, neutropenia, and thrombocytopenia. Anemia will be manifested in the form of pallor, fatigability, tachycardia, dyspnea, and finally lead to congestive heart failure. And neutropenia, since only the immature forms of B cells are available, the mature B cells are not there, so there is neutropenia. So there will be fever, infections, recurrent infections and ulcers in the mucosa. And thrombocytopenia will be manifested in the form of petechiae, where you can see in the image, and purpura and bleeding from the mucous membrane, and as well as the internal bleeding. And even for a minor trauma, they'll get bleeding. And there will be lymphadenopathy in this hepatosplenomegaly will be one of the important manifestation in hematological system. So you can see this hepatosplenomegaly of this child. And regarding extramedullary manifestations, it occurs when the cancer cells spread from the bone marrow. So the most dangerous manifestation is the CNS involvement, where it will cause the raised ICP, intracranial pressure. So it can lead to any cranial nerve palsy, convulsions, and cerebellar involvement in the form of ataxia, hypotonia, hyperreflexia. And if it affects the pituitary gland, it will cause diabetes insipidus. And the most serious complication, extramedullary manifestation, is the CNS hemorrhage. This CNS hemorrhage occurs because of raised ICP as well as the thrombocytopenia that is present. And next most common is this genitourinary tract involvement, where in case of male children, there will be testicular enlargement, which will be painless. And classical presentation that the child will tell is the sternal tenderness. When we tap on the sternum, the patient will have the child will have very severe pain. This is one of the classical finding in acute lymphoblastic leukemia. And in case of gastrointestinal system, there will be GI bleeding. These are all the clinical features of acute lymphoblastic leukemia. So how can we diagnose this acute lymphoblastic leukemia? We can diagnose this with the help of a simple clinical scenario and a complete blood count and a peripheral smear. So in blood count, there will be anemia. So hemoglobin will be reduced. WBC may be normal, increased or low. If it is increased, it shows it's in leukemioid reaction. Platelet will be usually reduced. Peripheral smear demonstrates the presence of blast cells. Blast cells are immature cells of the WBCs. So we can confirm this by bone marrow aspiration and biopsy. A minimum of more than 5% of blast cell is used to say that it is ALL positive. So you can see the peripheral smear image here. It shows the blast cells. See these blast cells, it's a lymphoblast. So it's one of the precursor cell for lymphocytes. And but we have to know whether it is a B cell TLL or a B cell ALL or a T cell ALL. So in order to confirm that immunophenotyping using cytoflowmetry, flow cytometry can be done. Then in order to know the etiology, like some syndromes like Down syndrome, Bloom syndrome, so we have to know about the cytogenetics with the help of karyotyping. And as we all know, there will be sternal tenderness and there will be mediastinal mass, and this mediastinal mass can be confirmed with the help of chest X-ray. and serum electrolytes, routine serum electrolytes, urea, uric acid, LDH, LFT, and immunoglobulins can be done. In case if there is extramedullary involvement like CNS involvement, CSF examination should be done, and coagulation profile, and ECG, echocardiography, and sometimes it's associated with HIV, so HIV testing and USG abdomen for hepatosplenomegaly and MAN2 test for tuberculosis can also be done as a diagnosis part of acute lymphoblastic leukemia. So how can we classify this ALL? Is this FAB, French American British classification. So they categorize this ALL into L1, L2 and L3 based on some of the cytological features. So let's see this. So as the L1, L2, L3 severity number progresses, the severity is also progressing. So if you see the cell size, in L1 it will be very small cells. They are homogeneous mostly. L2 is L3 are large cells, and L2 will be heterogeneous, whereas L3 will again be homogeneous. Cytoplasm, it will be very scanty in L1, whereas in L2 it will be variable, and L3 it is as abundant cytoplasm. And as we all know, as the malignancy advances, the nucleoli will be present. So nucleoli will be very small in L1. Nucleoli will be one or more and often large in L2, and will be more prominent in L3 nucleoli. Even the shape will also be homogeneous in L1, nuclear shape homogeneous and regular, whereas in L2 it is heterogeneous and irregular, whereas again in L3 it is regular but it's a stippled homogeneous nuclear shape. And basophilia will be increased in L3, and cytoplasmic vacuolation will be prominent in L3. So this is how we classify the ALL. Coming to the immunophenotypic, so as we have already told, it can be either a B cell TLL or a T cell ALL. So if it is B cell, it can be an early pre-B cell, and a mature B cell. If it is a T cell, it can be a pro-T cell, pre-T cell, cortical T cell, or a mature T cell. And some prognostic factors like if the age is around 2 to 10 years, because the peak incidence is around 2 to 5 years. If the age is around 2 to 10 years, the baby only has standard risk. If less than 1 year or more than 10 years, if the child is getting ALL, then there is a high risk. As we have already told, males are at a higher risk than females. And the initial WBC count, if it is more than 50,000 cells per millimeter cube, then it's a higher risk. And if mediastinal mass is present, it's a higher risk. Coming to the treatment, so first we have chemotherapy. This chemotherapy can be given in 4 stages, namely induction phase, preventive therapy, consolidation, and continuation phase. In induction phase, we give it for a duration of 16 weeks to reduce the blast cell size drastically to amount less than 5%. So what drugs we will give here is prednisolone, vincristine, L-asparagine, and methotrexate. So we can remember this by the mnemonic PVLM. And in preventive therapy, this is mainly given for CNS prophylaxis, because all these chemotherapy drugs does not cross the blood-brain barrier. So we have to give a high dose of systemic chemotherapy or an intrathecal chemotherapy or a radiation therapy for CNS prophylaxis. Then consolidation phase, this phase is given for sensitization. This is given for a duration of half of the induction phase, that is 8 weeks. Here we are giving this chemotherapy agents mainly to reduce the disease burden. So we have the mnemonic called C2M2L. So cyclophosphamide, cytarabine, methotrexate, 6-mercaptopurine, and L-asparaginase. And in the continuation phase, again the same drugs like the induction phase, but additionally we are adding mercaptopurine. So here we have to give each cycle for a duration of 3 months, and 6 times this cycle has to be given. This is regarding chemotherapy. Then the definitive treatment is bone marrow transplant. This is indicated when there is a relapse of the symptoms, and when there is Philadelphia chromosome positive ALL, when there is a high risk T cell ALL. And finally, we have complications. As a result of this tumor lysis, we can have a tumor lysis syndrome, and this mediastinal mass will compress the superior vena cava, causing the SVC obstruction and febrile neutropenia. This is all we have to know about ALL, and thank you for listening.